Okay, I'd like to welcome everybody to the 17th UCD seminar COVID series that we've been running at UCD. My colleague, Dr. Bláthnaid Gavin, along with Paul Harkin from UCD, and this has been co-hosted by the College of Psychiatry in Ireland. We're going to have a record-breaking attendance today. I could think it's because the Leaving Cert CAO results are due out at about 2 o'clock. And we all have to find a way to suitably distract ourselves. But joking aside, it is a very stressful time for our students as they're waiting to get their CAO offers. So best of luck to anybody out there who's got a child or a friend or a relative who's waiting. We're delighted also to welcome today. Our audience has typically been drawn from the child psychiatry, adult psychiatry, and mental health related disciplines, but today we're being joined by our colleagues from Paediatrics, so welcome to all who attend, and hope you, if you like today's talk, which I have no doubt that you will, have a look at the other topics that we're offering over the next couple of months, and you might like to join us on those. Without further ado, I'm going to introduce our speaker, who is probably very well known to our paediatric colleagues and would also be known within child psychiatry. Professor Russell Viner is the first professor of adolescent health, and I think, Russell, that really is a testament to both your clinical acumen, but also your ability and your enthusiasm for moving things forward and working in the policy sphere, which you very much do. It could be said that you're ably helped by Dasha, your wife, who's also an expert in her own right, a child and adolescent psychiatrist.
That's certainly true.
But most of you will know Russell because he's also the president of the Royal College of Paediatrics and Child Health in the UK. And he's a very eminent clinician. His own areas of interest and research are in the area of diabetes and also in obesity. And it's interesting because both of those are risk factors for the current COVID pandemic, at least in the adult population and a little bit in the child as well. You're a very wealthy man by way of research grants, Russell. I don't know how it transfers. I won't say anything about what I know about you personally, but let's hope it applies personally as well. So looking forward very much to what's a very important area schools have opened up, that of susceptibility and transmission of COVID by children and young people.
Thank you, Fiona, and thank you for inviting me to speak to this audience, and welcome all. I wish, Fiona, I wish research grants would translate into personal wealth. Sadly, I think they're inversely related in my case. I seem to get poorer. But anyway, so schools, children, and coronavirus, a hugely complex area. And I'm not sure about the media and press in the Republic of Ireland, but certainly in the UK, this has been an absolute obsession of our public and our media for at least a month. In one sense, the paediatrician in me is very glad to see children and young people as a major priority in the news. But it's certainly something I've never quite seen before in my professional career, this incredible focus on children, a whole series of fears and concerns, and actually a lot of anxiety circulating in the press amongst politicians and amongst doctors as well. And it's been a really complex time. I'm going to talk to you particularly today about some of the research we've done on susceptibility and a little bit on transmission. I wanted to start by taking you back to the beginning of the pandemic and to talk about the issue around schools right back then. I might click onto my next slide. We published right at the beginning of the pandemic a systematic review on schools. Now, if I take you back to February and March, January, of course, we were hearing about reports of this new virus, and we were starting to get by February data suggesting that children in fact, were very little affected. So the early data came out of China. I remember the first couple of papers coming out on children, and this real surprise, I think, in a sense, that children seem to be almost nowhere in this pandemic. We were also, as the pandemic started to take off in Europe, particularly in Lombardy in Italy, we were talking to colleagues in Italy who were saying, actually, our children's wards are empty. We're seeing no children with this. Our pediatric intensive care units are empty. And we started to get the first sense that there was something different about this pandemic compared to classic pandemics, in a sense, which have largely, when I say classic pandemics, our experience of pandemics have particularly been influenza pandemics. As things exploded in Italy and started to move across the rest of Europe, and we started to be concerns about social distancing and lockdown across European countries, the issue of school closures, of course, dramatically came up. At that stage, there was very little data around. And one of the things we did, linked into the Chief Medical Officer office here in the UK, was a very rapid review of what was known about schools, the impacts of school closures, about school transmission with coronavirus, because I'm sure you're aware there were 2 previous coronavirus outbreaks, not pandemics per se. One was the original SARS and then MERS. So we wanted to look back at what was known, not necessarily about children, because actually some colleagues of mine were doing a rapid review of what was known about children in SARS and MERS, and then COVID at that time. But we did a review on what was known about transmission in schools and the impact. Had there been school closures during SARS or MERS? What do we know about the impact of those? And what did we understand about transmission in schools from SARS and MERS? So that was what we felt we could do. We did a rapid review published in The Lancet at that time. We had about 16 or 17 papers we were able to include in that review. Only one of them was from COVID-19, because there was really no data out at that time. And the only paper we were able to include was a modeling study. Well, there were no data from MERS, no data at all from MERS, and as you probably know, MERS really was a relatively minor outbreak. There was some data from SARS, from China, from Hong Kong, from Taiwan, and Singapore were the countries that SARS were. Those data showed there was very little evidence of transmission in schools. There were no significant data on school closures. We were able to find some data on when schools were closed, but there were no analytic data on the impact of school closures. What we did also note was the difference between coronavirus and influenza. And we noted that most of our understanding of school transmission and the role of schools in pandemics and the potential for school closures all came from influenza. Not just the H1N1 pandemic in 2009, but a range of both seasonal influenza that occurs every year and then other influenza pandemics. There are actually a very useful number of systematic reviews on influenza and school closures and school transmission, which we were able to refer to. And it became clear that there were a number of significant differences emerging between influenza pandemics and the COVID-19 pandemic. One was the R value, the reproductive number. And interestingly, there was evidence from the influenza epidemics that when R values were high, and the R value, as you know, for SARS-CoV-2 is the virus that causes COVID-19. I'll use them a bit interchangeably here. There's the reproduction number for SARS-CoV-2 was high, so estimates at 2, 3, 4. Now, in one sense, that's low compared to measles or pertussis, which are up at 8 to 12, but that's high compared to influenza. And I think the evidence was that the higher the reproductive number, the less effective school closures were, which was interesting. And part of it was about whether children were super spreaders or not. And again, the children spread different versions of influenza in slightly different ways. So we were able to take some data from the influenza data and say, if COVID-19 is behaving like this, and given what we knew about SARS from 2003, that suggested that schools played a relatively limited role. They weren't the most obvious thing to do up front. However, there were very few data, so it was a systematic review that was published early that had very tentative findings. But the findings were that school closures should, logically played only a relatively minor role in controlling this pandemic and might be implemented late. This was published at the time there was a massive rush to close schools. You probably realize that when one comes out with this kind of data, it suddenly becomes incredibly controversial. And at the time there were very little data around. This was, we got a lot of stick for this. Some people who were very, very scared about what was going to happen were very critical. Others were absolutely behind us. So it was very interesting. And you probably won't be surprised to know that this is a cartoon from Australia. And I think on the left-hand side is the federal government singing "Keep the Schools Open" refrain. This was at the time they were talking about Victoria, state of Victoria saying close, state of Queensland with the tuba here, shutting everything down. Singing from the same hymn book. There was a lot of concern. I should say, and I meant to say this before, by the way, Fiona introduced me before, my expertise is in public health, particularly from a clinical point of view, diabetes, obesity, broader adolescent health. I think like many people, we've become experts on COVID-19. I don't have a background in virology per se, but we've all been very, very rapid learners. So that was early on, and data started to emerge about the role of children. But particularly as we started to get into early May, started to be questions about, okay, when do European countries and others start to reopen schools? And of course, huge questions about the balance of risks, about what are the harms of keeping schools closed and what might be the harms of opening them. And I feel like I've spent my last, certainly since about April, May, I've spent much of my time talking in the media, talking to others, trying to avoid the question, is it safe to reopen schools? And challenge that question straight back and say, of course, there's no such thing as safe. And make it clear that this is about a balance of risks. What are the harms of keeping schools closed as opposed to the potential benefits of opening schools, and making sure that both sides of the equation were in there, not just the risks of COVID-19, but also the risks to children and young people's physical and mental health and well-being from keeping schools closed. And that's been a difficult discussion because certainly April, May, June, the operating culture was fear of SARS-CoV-2 and this incredible anxiety and this belief that comes from the past that children were major spreaders of this virus. Now, we build schools to transmit ideas, and they do that really very well. Sometimes schools transmit ideas too well, and we've certainly seen radicalization through schools and a whole lot of other ideas coming through schools that are, very problematic. Schools are generally very good at transmitting bugs as well. So lice, outbreaks in schools, impetigo, measles, meningitis. But interestingly, the data has accumulated over time that schools are not particularly good at transmitting SARS-CoV-2. Anyway, I'll come on to a bit of that. One of the key things I wanted to start with was this issue of the chain of transmission. And I put this slide up because it's really important to try and understand the different bits of data there are about transmission and what different studies tell us. And again, I think this is something that I've spent much of my last 6 months talking about. One of the things I observed, and you probably observed as well, is there's been a drip feed of research that comes into the media, produces a brief hysteria, and then suddenly the journalists and everybody's on to the next study. And there are many studies that come out that tell us something about the question about children and schools, but no study tells us the whole picture. But what I would observe would be a study might come out on viral load, so the amount of virus in children's noses, and suddenly everybody's rushing over to the left saying, oh my God, children are massive transmitters. And then a study might come out saying actually, which is an epidemiological study that looks actually at transmission within schools. And everybody suddenly rushes to the right and says, aha, there's no evidence of transmission in schools. And then the next study on nasopharyngeal viral load and viral shedding comes out and everybody rushes over to the left. And I've put this diagram together, by the way, yeah, and I've tried to break it up. This is an old version of the diagram. Now I have a slightly different one, into the issues around catching SARS-CoV-2, which is particularly around susceptibility. And we can argue about whether exposure or susceptibility should come first in this diagram, but anyway. And then there's the issue about transmitting SARS-CoV-2. And actually much of the data tell us different things. Many of the studies tell us about susceptibility, but don't tell us anything about transmission. But in the public mind, and I think in the mind of many doctors, often these two things are very, very interlinked. So in a basic sense, we have a number of different types of studies. Contact tracing studies, which are the sort of classic epidemiological studies, can tell us about susceptibility, which is the question, do children and young people, are they as likely to catch SARS-CoV-2 from an exposure as an adult? So that's an exposure question and a susceptibility question, which are very much answered well by contact tracing studies. Contact tracing studies can also answer the question about transmission if they look at children as the index or the first case, and then look at how much they pass that on to either other children or to adults. So they can also answer transmission questions. There are also other studies, prevalence studies, which might be virus prevalence studies, how much virus prevalence is in the population. And secondly, antibody prevalence studies. They give us very indirect measures of susceptibility, and they tell us almost nothing about transmission. But people will take a seroprevalence study and say, oh, this tells us about transmission. And the third group are particularly the more biological studies, such as of the amount of virus in children's noses. There might be a study of the aerosolization of COVID-19 from a child in an experimental situation coughing. There might be studies of antibodies. There's a number of biological studies. And of course, each of those biological studies are I see them in a sense as being theoretical knowledge, because they don't tell us about susceptibility or transmission in the real world. It's only population-based studies looking at large groups of children that tell us about susceptibility or transmission in the real world. Okay, so I'm going to move on now to talk about the systematic review and meta-analysis we've done. This is a systematic review and meta-analysis, particularly focusing on susceptibility. This paper is coming out in JAMA Paediatrics, hopefully within the next 2 weeks. It's been quite a long gestation. This paper was originally published in May. This is a preprint, so you can see the date, the 20th of May date there. It's interesting, of course, as you will all know, we've seen a dramatic shift in our publishing. For those of us trying to influence the public, trying to influence politicians, even as good, supposedly, ambitious academics, I shouldn't say good academics, ambitious academics like me, it's much more important to me to get out there into the public eye than to get something into a good journal. So we got this originally out in May in a preprint. We updated it in August. So we now have an update of this review, and we've split the review, and the review that will come out will be only on susceptibility, and that's what I'll mostly speak about today. And I'm in a weird way, I'm frankly appalled that it's taken 3 months for this to come out in a journal. But the important thing is we were out there pushing, getting these data out there, influencing people with this study, and it certainly influenced policy in the UK, and I think more broadly. It's the only real systematic review out there that really looks at this very carefully. We decided we would only look at 2 types of studies, so epidemiological studies, contact tracing studies, or prevalence studies. We did not look at the biological studies, for example, of viral load and others, because as I said, to my mind, they're very important enabling studies. My understanding of them, by the way, thus far, is that they tell us about individual children in particular, and we know that individual children can be highly infectious, and individual children can transmit this virus. We absolutely know that. I think the real questions are, in the real world, in real world settings, how much are they susceptible and how much do they transmit? So what did we find? So we undertook a systematic review. We found around 16 contact tracing studies, of which 15 of them were suitable for meta-analysis here. This is a meta-analysis with a forest plot. Now, I think many of you have seen this kind of work before, but just to remind you, we have the study name on the left. Forget the forest plot for the moment. Here, the positive and negative are, this is the odds of being an infected contact for children compared to adults. So let's take this top study for example. This was a top study that had 10 children and around 179 adults in it. So it's a Chinese study, one of the very early ones. And this looked at households and looked at the chances of a child in the household or an adult in the household being infected by somebody in their house by being a close contact of someone with proven SARS-CoV-2 infection. So quality studies, you have to prove the infection, you have to have very high quality contact tracing, you have to test absolutely all of your contacts, and you have to follow them up and quarantine them for 14 days. So unsurprisingly, many of these studies, in fact, most of them were done in China. And then we get the odds of being an infected contact in a child compared to being in an adult. And you can see here for this study, the odds ratio, children were very protected against becoming an infected contact, suggesting they had lower susceptibility. So this was a random effects meta-analysis. These are the weights in all the studies, and you can see the great majority of the studies were on the left-hand side of 1. 1 is essentially suggesting there's no difference between the susceptibility of children or adults. There was only one study here that suggested that children were at higher risk of being infected contacts. And this, interesting, was a very large study, and quite a recently published one from South Korea by Park. So there's a few very large studies. This one from India by Laxminarayan, a big study from Wuhan in the province, Hubei, and this big study from Park, but also some other big studies here. And these studies come from Japan, from Israel, 2 studies from the US, from Brunei, 6 studies from China, and again, as I said, from India and from South Korea. The pooled estimate was 0.56 odds ratio. So children and young people had a 44% lower odds of being an infected contact. Put bluntly, they had about a 40% lower risk of catching SARS-CoV-2 if they were in contact with somebody who was infected. Now, these are very robust studies in general, done well, and this is, we think, a robust systematic review of meta-analysis, so we're fairly comfortable with that finding. There is a remaining suspicion that it's possible that early on in this pandemic and through much of it, the children were exposed less than adults. And that's the danger. Our knowledge are evolving in this pandemic, undoubtedly. And part of the danger is that there may be, despite our best attempts to only include high quality studies, to carefully examine, and we carefully examined bias, we only included studies that were really relatively, we didn't only include high quality studies, I won't say that, but we very carefully looked at the studies. We did sensitivity analyses, dropping out the low quality studies. But I think that's probably a fairly robust finding, but we have to caveat it, which is saying we're only 6 months into this pandemic. It is possible that there's something about this social mixing that is giving some systematic bias to this. One of the things that's really important to say, and sorry, I should have said it earlier, is that it's essential to only look at well-done case control studies or population-based prevalence studies. In fact, I'm going to move on to the prevalence studies next. But before I move on to those, these are population-based prevalence studies. We did not include any of the national COVID registries because they give you a very distorted view on the susceptibility of children. I imagine that the National COVID Registry in Ireland is very similar to the one in the UK. It will show the vast majority of infections are in adults, and probably 1 to 2 to 3% of positive cases of COVID-19 have been in children and young people under 18 or 19. I'm sure that's what your national registry shows, because that's what the national registry of every single country shows. And people interpret that as suggesting that children are immune to this virus or have low susceptibility, and that they don't pass this virus on, both of which are false assumptions. Obviously, it could tell us something about susceptibility, and I'll tell you why it doesn't in a minute, but the fact that children are very low proportions of national cases clearly tells us nothing about transmission. Why does it tell us very little about susceptibility? Because national COVID registers are based on testing because of symptoms. And children are very, very unlikely, not very unlikely, in general, most children are asymptomatic. There was a recent study out from Northern Ireland which caused a bit of a flurry, and I won't go into that in too much detail. Various people will suddenly come up and say, children aren't so asymptomatic. If you look carefully, children have all of these symptoms. And the answer is, children have symptoms from every infection. Every time a child has a fever, they will often have a loose stool or a bit of abdominal pain, as every paediatrician and probably every child and adolescent psychiatrist knows. But many children with COVID certainly don't even have a fever. You may, with some in-depth discussions, find that they have some loose stool or some other symptoms. But in general, certainly in terms of the classic COVID symptoms, most probably somewhere, I think the data is 60 to 80%, totally depending on study, are mostly asymptomatic. So going back to my original point, a national COVID registry where you only test people if they have symptoms will miss all of the asymptomatic children, or the vast majority of them. Adults, for example, are much more likely to have symptoms. If you have COVID as an adult, particularly if you're over 30 or 40, you probably have symptoms. Therefore, many of the cases get tested. So the national registries or symptom-based finding is absolutely misleading. So this is a meta-analysis. Oh, sorry, I'm not going to come on yet onto the prevalence study. Sorry, I forgot one slide to show you. Remember I said there was that one study that seemed to suggest that children and young people had higher susceptibility than adults. When you cut things by under 12 to 14 compared to over 10 to 14, you find a much stronger signal for children, and actually the signal for teenagers disappears. The data for teenagers here are very, they're a bit all over the place. I think that means we can't assume that adolescents are less susceptible than adults. It's possible they might be. I don't believe the Park study here This suggests they're more susceptible. There were major problems with numbers. And there are major issues here about contact tracing. If you contact trace for children, of course, you talk to their parents. If you contact trace for adolescents, the question is, who do you ask about their contacts? Often their parents won't know who their contacts have been. And I think children and adolescents themselves are often reluctant to tell on their friends and tell who their contacts are. And so there's a bit of systematic bias in that the contact numbers for adolescents are often very low. So if you have a number of cases, but systematically lower contact numbers, you will always find potentially a higher proportion of secondary cases in adolescents. So there's some interesting systemic biases there. Okay, now I was going to make my point about prevalence studies. We looked for prevalence studies that weren't national registries, that they weren't residual sera studies, and we've got to be careful of those. There's a number of studies coming out saying we grabbed all the blood we could find from all the laboratories around the country and tested them for COVID antibodies. There's big studies out of the US and lots of other places doing that. And of course, in general, children very rarely give blood. And if they do, the children that get blood taken are generally those with chronic conditions and a range of susceptibility factors for COVID-19. People also do studies of patients who come to primary care, to GPs and others. And of course, they're again just going to be a source of systematic bias. Anyway, we found there were 3 very large national seroprevalence studies, one in the Netherlands, one from Spain, and then one from Brazil. This was a very interesting study, the one from Brazil. It was very interesting to read. Their blood collectors got beaten up in 10 out of the 40 cities they were involved in, particularly those in the upper Amazon. They got arrested. They were forbidden by city mayors to take blood. They were, there's a lot of unrest in Brazil about COVID-19. So we have to be slightly suspicious of their findings slightly. Anyway, lower risk, lower prevalence of COVID-19 antibodies in those studies. There were a few what I would call regional or municipal seroprevalence studies from the US, from Geneva, from Iran, again from the US. Sorry, this one's from Japan. Mixed findings. Outbreak seroprevalence studies. So 3 really important studies where they took a small town. 2 of these were in Germany, one was in Italy. A small town where there'd been a really big outbreak. So a town of, say, 1,000 to 3,000 people. And they very religiously tested everyone in the town for COVID and did COVID antibodies up to 6 to 8 weeks later. And again, children, lower risk here. And then there were some virus prevalence studies. This is the big Icelandic study, which has been widely reported. This was back in March. They found 100 cases out of 12,000 adults. Oops, sorry. I've gone ahead some reason or other, but none out of nearly 1,000 cases in children. Here, I think there's a range of findings. I should mention school contact tracing studies as well. There have been 3 of these published. One from the Republic of Ireland by Heavey, which was a study of, a contact tracing study of 3 or 4 cases, I think, that were seen in schools before schools closed, back before lockdown. There was a similar study from Singapore back before schools closed, but they were quite small scale studies. Much bigger study from New South Wales, which has been published recently in the Lancet Child and Adolescent Health. Essentially, they found very few primary cases in schools, very little secondary transmission, and a very low secondary attack rate of only about 1%, which is much, much lower than you see in households and in other community settings. So what are the conclusions then? I think this is a complex area we're still learning. There may be systematic bias that is still affecting, I shouldn't say infecting, all of our findings. But I think there's fairly good evidence that children under 12 to 14 are about 40% less likely to be infected with SARS-CoV-2. The data for adolescents are unclear. but we should assume a similar susceptibility. Transmission. Now, there are other transmission data, and we've split our systematic review. We're actually finalizing a similar-ish systematic review on transmission. Essentially, the data from New South Wales, from Republic of Ireland, and from Singapore are now joined by a number of others, studies, outbreak studies from Japan or Germany and others, some of which are in preprint, some of which are informally published, some of which I know about, but they're not yet published. What do we know about schools? There are outbreaks in schools, of course there are. Children are human beings and they transmit this virus. However, children, particularly children probably under 16 to 18, appear to play quite a limited role in transmission of this pandemic. Where outbreaks occur in schools, outbreaks are small. It's mostly staff that are infected rather than students. And most of the studies find very little evidence of child to child or child to adult transmission, particularly in schools. So to my mind, there's something about children and lower transmission there. There may be something also about schools and lower levels of transmission. Schools are relatively contained places, particularly, post-pandemic. Schools are putting in place a range of mitigations. And actually, we have very little evidence of significant transmission in schools. There are 3 to 4 reports of outbreaks in schools, of course. It's interesting, these are major outbreaks, so, affecting, 20 or more cases. But it's interesting that there's only that smaller number compared to the number of cases of SARS-CoV-2 in adults and more generally. And again, I think, so asking the question, is it safe to reopen schools, is the wrong question. It's only about a balance of risks. The risks of COVID-19 to children are incredibly small. Children play a limited role in transmission of this virus. And I think that's true for younger children. And I think it's also true for older adolescents, but we're less secure about that finding. There is transmission in schools. Much of it is brought in from outside and then transmitted in schools by adults, not by children. I'm going to finish there. I may say one last thing. If somebody asks me about, actually, somebody can ask me about masks in the discussion rather than me banging on. I'm going to leave it there. Thank you. I might stop sharing my screen now. There. Thank you.
Russell, thank you very much for that presentation. I forgot to mention at the start, but just to let all the audience know, if you would like to ask a question, you can either send it to me on the chat, or you might wish to ask the question yourself. If we're able to manage that in an orderly fashion, it would be nice to get some discussion going. So I guess you were talking about susceptibility more so rather than transmission, Russell. And the data from the States, there has been, even before school started at the end of August, beginning of September, they've had a significant rise in cases in children being diagnosed. I'm not clear whether that was based on symptom presentation, whether they can account for that by increased testing or whether there is a sense of increased infections. But if there's a sense that, in part they're not transmitting it as much, in terms of, is there any real idea of, now I know you said we don't know because they're mostly asymptomatic, but has there been any prevalence study done that makes you think it's a good base rate to feel that, the rate of, I know this applies to adults as well, it's not even clear what the percentage in the adult population is. But do you have an idea of how many children who, symptomatic or not, might be COVID positive?
So if I go back to, the prevalence studies, the prevalence studies do give us an estimate of that, the ones I showed. Now, obviously a prevalence study is a prevalence study at a point in time. So they give different answers. And the way we've been showing the data is prevalence in children compared with adults. A recent a recent seroprevalence study in the UK was suggesting that around 10% of children have antibodies. And seroprevalence is, we think, is probably the best measure of who's had it. We still don't know how long-lasting antibodies are and how meaningful they are, but we do know that virus prevalence studies are only as good as the time that the virus is detectable. And we're still a bit unclear on how long that is in children compared with adults. Going back 2 steps, the issue about higher numbers of children in testing. I mean, it becomes incredibly complex. In the US, President Trump got into appropriately lots of trouble for saying it was all due to increasing in testing, but there are issues about increases in testing. Scotland is an interesting case in point. Scotland had an over 900% increase in the amount of children and young people that were tested between early August and early September. 943% increase in testing. It was extraordinary because schools in Scotland reopened in the middle of August. The numbers who were positive went up dramatically. Well, of course they did, because they were testing. They tested up to 40,000. Whereas they'd been previously testing much lower in the hundreds and then 1,000. But the actual proportion of tests that were positive dropped massively. So they did a lot more tests. They found a lot more positives. However, the proportion of the tests that were positive dropped from around 2% down to 0.3%. So it's a classic example of seek and you will find, but actually it needs to be thought of in the context of the population. And as we have more tests around and as schools are reopening, almost every country is testing a lot more asymptomatic children. So we are finding asymptomatic children that we never found before. And we need to be careful to put those data in context. They don't tell us there's more of it around necessarily. So it's a very difficult balancing point, I think. Yeah.
That sense that, fewer of them proportionally were infected, that in some ways it was due to the increased numbers of testing. That's a little bit at odds with what the recent data, just in the last night or two that came out from the UK looking at, the older age group, the 17, 18, 19-year-old group. Do you want to say a little bit about that? Yeah.
So I don't know that it's necessarily at odds with that, to be honest, because there are many more numbers. So what we're seeing, interestingly, is a shift in the age distribution of tests. And it may be something to do with testing. It may also be due to a lot about social mixing. Back in March, I remember being shocked by the data from South Korea, which showed that around 1/3 of the cases in South Korea were in 20 to 29-year-olds. And of course, at the time in the UK, and I think the same in Ireland, I assume the same in Ireland, I don't know, the great majority of our cases were all in 50 plus, 60 plus, 80 plus age groups. So we were suddenly thinking, what's different about South Korea? And of course, the difference was a difference in testing. Back in March, the UK and many European countries were only testing in hospitals because we did not have the testing capacity to test in the community. So we only tested in hospital, and the people who got to hospital were those who were sick with COVID, which of course was the elderly. Children very rarely get sick with COVID-19. They very rarely get tested and treated. We've had a shift in our testing. We now in the UK have a lot of community testing available. I mean, they can do, I think, 400,000 tests. Is it a week? Or is it a day? I can't remember. It may be a week. We can do vast numbers of tests. And many people who are well are now getting tested. So I think that's part of it, is that these cases were probably there before, but we didn't see them. Secondly, I think that there is probably increased uptake in these age groups. So 17, 18, but particularly 20 through to 29s. They're a very vulnerable group in lots of ways. When they live outside of home, and many of these young people do live outside of home, they live in all adult households. Therefore, they're exposed to all adults. Whereas if you live in families with children, and if children play less of a role in transmission and are less susceptible, if you're an adult living in a family that has children in it, if there's 2 adults and 4 children, for example, it's very different to being in a multi-adult household, which is what a lot of young people live in. Young people are generally in the poorer parts of society, and young people are not the kind of people that can work from home in many occupations. So clearly students can, or have been, but for many young people who are still in work, the 20 to 29-year-olds, they're the kind of young people that have to go to work. Whereas, of course, a lot of the older, more professional workers can work from home. And then lastly, young people socialize in different ways. So there probably are a range of reasons, and that it may be in part testing, and I'm sure it is in part testing, but there may also be reasons that, things are shifting towards circulating in our 20 to 29-year-olds. We've certainly not seen that in our younger children. And I think that fits with what I've been saying before, that we have evidence that younger children are less susceptible, but probably doesn't apply to adolescents, though we're uncertain.
One of our colleagues, Dr. Kelleher, is kind of agreeing with that, given their low transmission rates, whether a mask and a plastic apron theoretically should be adequate in schools, with adequate hand hygiene.
It's an incredibly complex area. And luckily in the UK, I tend to get away with this I tend to often be in meetings where I can say, look, I'm telling you about the science. My colleague here will tell you about the policy implications of the science. When I'm doing some work for government or whatever, because of course they've got the difficult job of saying, okay, that's the science, what should we do? It's a complex area, particularly the issue of doing aerosolization, APGs, aerosol generating procedures within schools. So for kids with trachees or whatever, I think is a really complex area. I think there's logic to what your colleague said. However, I think certainly in the UK, and I suspect in other countries, education unions and teachers unions would see this as them being, in a sense, guinea pigs. So we've certainly taken the view in the UK that aerosol generating procedures need PPE. And I think the answer is we don't know. And it depends what standpoint you come from to make that decision.
Another colleague has, Dr. Rob Cunny, has suggested that in a way that maybe precautions and restrictions should follow clinical presentation. He suggests that maybe there should be a more horizontal approach, so that, if you have a positive test, it may show either, current virus or past virus, and that actually that person may not have sufficient load to be infective. And whether it is possible to apply restrictions based on clinical presentation and the risk of transmission to others. I guess the difficulty there is that, who's going to be, if we're talking about a school scenario, who's going to be establishing clinical presentations, and the atypicality of presentation within kids, might make that difficult.
Yeah. I think that's right. I think there are no easy answers in all of these things.
In terms of the negative impacts of school closure, I mean, we're feeling it today because of the Leaving Cert students, the whole experience they have. And I imagine for many kids, this is going to continue for a long time. The CEO results, are one thing, it may be years before for some of them, they get back to where they might have been. But one wonders whether schools were closed too quickly. Now, I know part of it is there's no point crying about spilt milk, but I guess, it's inevitable that there's going to be more waves in this virus as we go forward. And there will be, you know, the same people that wanted them closed will be asking for that again, and the tension between the two groups. Have you advice or policy advice, Russell, about going forward? You know, schools are reopening. How should they?
We have a very strong view that schools should only be closed in extremis in the future. I have a very strong view. The Royal College has that view, and I think, you know, the date, it might, you know, I've been engaged on a sort of science-based advocacy mission over the last 3 or 4 months. Firstly, to reduce the collateral damage to children from COVID in terms of clinical services and others. Secondly, to get schools open. And then thirdly, to make sure that they don't close schools again, and that in any future pandemic wave, children's services aren't too affected. You know, that's, and to use the science we have from these studies and others to make those arguments to government. And I think actually it's interesting, it's quite well accepted now in the UK that school closures will be late in any local lockdown. The UK, and I think many countries, want to avoid national lockdowns in future and are trying to rely on local lockdowns. And the guidance here is that there will be, that, you know, students and years are in bubbles, that there is some reactive school closure if there's some evidence of significant transmission, that bubbles or classes or even a year group get suspended for short periods. But closures of any individual school is a very rare event, and closures of all schools should be resisted as far as possible. Certainly in the UK, there are a number of areas where there are increased restrictions, and in none of those places have schools been closed.
And we're just about to reopen all our universities, and, you know, we've spoken about both the increased numbers, you know, not only being increased testing, but true infection and difficulties with social behavior, and the fact that adolescents and young adults are so socially driven. Yeah. And it's important that they are. But I guess, you know, how can one, you know, school is a confined setting. It might be slightly easier to have certain things in place. University campuses are far bigger, and
I think on university campuses, we have to almost take an occupational view. I think there is risk, but again, I think given the life chances of our young people and actually the, you know, the good of the nation, I think it's a balance of risks. I'm a supporter of universities being open, but I think we need to take the kind of view that we would in occupations, in office settings and others, for students.
Do you think, Russell, now I know this is kind of deviating from the children into the slightly younger adult, but I guess, you know, it's so important. What we're talking about here is behavior change, and how you get, you know, the general public, each of us, to accept responsibility for our behavior. And the fact that we know it must be, you know, that you have to convince somebody, and Sam McConkey and other people are doing excellent jobs on the television convincing people that they should take personal responsibility. And then you have on the opposite side, you know, sadly, Golfgate in Ireland, where there's a sense that not everybody is following it.
Yes.
But do you think there should be actually more of a focus at all age groups around, you know, the concepts of behavioral change and how we encourage and bring people along with us in each of the different groups, be it socioeconomic or age or ethnicity?
Absolutely, absolutely. I'm part of, so we have something in Britain called SAGE, which is a scientific advisory group of experts to government. That's the, you know, the peak scientific advisory body that guides the coronavirus response, and I'm on a couple of their subcommittees on SAGE, and one of them is a behavioural science subcommittee, which we've looked at a number of these things, particularly around how we promote adherence by young people, by men in particular. These young men, so both young people but also men, seem to have poorer adherence. But I don't know that I think we've been very successful in getting government to think about that much and listen to it. Government tends to prefer the big stick,
Mm.
You know, they pay lip service to behavioral science, but they don't. It's not clear that they actually embrace those issues.
And then coming towards the end here, just kind of thinking a little bit more about high-risk groups. I know kids with asthma, for example, are more likely to catch the virus, as far as I understand, not necessarily be, you know, have worse clinical symptoms. But then there's another group that, you know, immunocompromised, cardiac, or, you know, even in obesity within children. Should parents, or should schools, or there's always the risk of stigmatizing people in an effort to protect them, but should we be kind of reminding ourselves about maybe some children who are more at risk, and maybe, you know, considering?
Yeah, I think we need to be quite precise about the risk factors. We don't know anything about the risk factors for catching coronavirus. In terms of catching SARS-CoV-2. We do know what the risk factors are for getting more severe disease. And the things that you mentioned are risk factors for severity, not risk factors for catching. And given that severe disease is so incredibly rare in children, I mean, it really is very, very rare. You know, we had 70 odd children admitted to intensive care across the whole of the UK. Maybe it's 70, that was England, 71. I think across the whole of the UK, it was about 76. You know, really, I mean, it's actually very, very small numbers. The vast majority of them did very well. You know, compared to numbers of infections and the pandemic amongst adults. I think, so the main risk group in Britain for risk of dying or severe disease is actually complex neurodisability who also have respiratory problems. So there is a little there, and I think we've seen that across Europe as well, that there is a little bit of signal from immunocompromised kids having cancer treatment. There's a little bit of signal from a couple of other conditions, but the big group that I think are concerning are those with complex neurodisability, also with respiratory problems, which may be children on long-term ventilation. And let's be clear, those children are at significant risk from any winter virus, any winter. In fact, the number of deaths in the UK has been very similar to the number of deaths we have from influenza in any given year on average. That's
it goes back really to proportional responses.
So I think it's proportional. So I don't think we should be having any other response around children with obesity, or children from, you know, non-white ethnic groups are often also at slightly higher risk of getting more severe disease, or children with bog standard asthma. But I think those who have significant respiratory compromise, particularly if it's neurodisability plus that, or kids with cancer treatment, I mean, I'm sure they are getting the appropriate warnings about being careful.
Mm. And just going to end with a question that you said you'd come back to, and one of the group has asked, which is your opinion about masks, and I guess Brilliant. What sort of masks?
Yes, and it's really important to say this is my opinion, my evidence-informed opinion, because I don't think anybody can make an evidence-based opinion about masks in children, because as far as I can see, the evidence is zero for children and young people. The WHO put out a statement on this. There was essentially an expert opinion. They noted that there is an evidence that children use masks poorly, but across influenza and a range of other conditions. But actually we have almost no evidence on the efficacy of masks. So given that the efficacy of masks in coronavirus is pretty marginal, it took a long time for many countries to adopt them because the evidence really is marginal. And I think the evidence is there now, but it's not an overwhelming evidence. Given what we know about children and the potential harms, and given that mask wearing is often poor, I'm not a great supporter of mask wearing in children. I quite like where many countries have got up to, where the UK's got up to, which is no requirement for children under 12 to wear masks, and children, other secondary school children should wear masks only on school transport and when in school corridors. But I think we should really try and resist masks in classrooms, because the evidence on transmission in classrooms is so low. It's, you know, there's such little evidence of transmission in classrooms.
Last question about when kids are visiting grandparents, maybe those that are susceptible by virtue of their own medical issues. Recommendations there?
I think it's an impossible question to give a science-based answer to. And my personal take is that children should be able to see grandparents, but maybe a quick hug, no kissing, you know, but a quick hug, possibly with faces turned away, keep the social distancing. But I don't think grandparents should be terrified of aerosolization from children in the room. If children are all ill, I don't think, anyway, I don't set policy, but the science would suggest to me that the balance of risks is for children to see their grandparents outside if possible, quick hug, but avoid the obvious risk factors. Wash hands between, after, blah, etc.
Right. Russell, we'd love to chat for longer, but in the interest of all our busy clinicians here, both paediatricians and psychiatrists and any other person who has joined us, I guess we better draw this session to a close. Thank you so much for giving the presentation. Thank you. And just to let the new audience members know that our next webinar next Friday is by Ellie Brown from Oregon, and that's going to be talking about the impact of COVID on psychosis. And then just to say, after that, we're also having on the 16th of October a morning event, which is the occupational stress and burnout that maybe some of us are beginning to feel as we are battling with this, not only the virus itself, but the restrictions that have been now part of our life. So we would be delighted for all of you to come and join us on that if you wish. It's a lovely sunny day. I think the best thing is outdoors, and we were about in England, in the UK, Russell, you'd have to be counting up the number of people in your household now. A lot of confusion about the 6 members. We haven't got there yet. We were dreading it this weekend. We're going to have an announcement next Tuesday, and everybody was dreading how many people we're going to be allowed to meet. But everybody better enjoy the weekend sensibly, practicing good social distancing. And we look forward to seeing everybody maybe next week. Thank you all for attending. All the best.
Cheers. Bye.